Good afternoon. Welcome. Thank you so much for joining us today. My name is Meredith Ramondi, and I'm the Vice President of Policy and Communications at the National Council of Urban Indian Health, otherwise known as NCUIH. And I'm so happy to be joined today for this discussion on health equity and action in partnership with the Pfizer Multicultural Collaborative and Dr. Myron Terry and Dr. Michael Toedt. And just before we get started, I will be the moderator today, and our panel will consist of our friend, Dr. Michael Toedt, former Chief Medical Officer for the Indian Health Service, and Myron Terry, who you may have seen as a speaker at NCUIH's conference earlier this year. He is also the Senior Director and Team Leader of Political Outreach at Pfizer. We're going to start out with a quick presentation, a few presentations today. First, we'll have Myron Terry, then we will have Dr. Toedt, and I will finish it up, and then there will be a Q&A at the end. Before we get started, we do have a video to share with you.
Is needed because our partners are telling us that it's needed. They told us that we can use our voice to really help amplify what's happening in the community around health equity, and also to identify what more needs to be done.
I joined today's conversation because there's still so much work that we have to do around health equity.
In the height of the quarantine, that we knew all these issues persisted and existed, but just as the summit is called Health Equity in Action, we're actually doing something about it. So actually hearing about practical solutions, concrete ways to change patient and community healthcare, it's phenomenal to be part of this group.
We talk about racial health inequities, but we don't talk a lot about the solutions. And so to be able to come to this session where there's so many different diverse perspectives, talking about what we can do about these racial health inequities, I feel like we could actually make a difference today.
Thank you. That video is the theme of today's call and why we're all here. And we are so grateful for our partners at Pfizer for their work on the Multicultural Health Equity Collective. These conversations are very important to the furthering and bettering of health outcomes for American Indians and Alaska Natives. And it is my honor to introduce Mr. Myron Terry.
Good afternoon, and first and foremost, thank you. And I guess it's a good sign because you've invited me back. So I guess I did okay the last time. I really enjoyed that conversation with the group, and part of what I think made that such a good conversation was that there was just so much back and forth, and the folks in the audience were so participatory and offered so many great comments. And I am really genuinely excited to be back with you here today and to sort of continue that dialogue. Health equity in action. And as you go, we can go to the next slide. You just saw a quick video recap of the meeting we had in October in Atlanta. And I think it was a monumental event, both for Pfizer and for our communities, because it really marked a sort of significant step forward in one, not just the conversations, but really a discussion about solutions, about what we could do to address what we all are well aware of some of the inequities in the healthcare system. Let's go to the next slide. And again, great participation, just great engagement from a lot of folks from sort of across the scale. Let's go to the next slide. But sort of dive right into it. And so the meeting really focused on 4 key areas. 1 was research and data, 2, health facility, healthcare delivery, 3, policy, 4, healthcare workforce pipeline. For our purposes today, we want to do a deeper dive into the policy bucket. And let's go to that next slide, please. And so when we're talking about policy, what are we really talking about? What are the key components of that conversation? Number 1, and again, a lot of this we know because we're the folks, particularly you are the folks sort of out there in the community doing this work every day. But when we talk about policy and when others are talking about policy, particularly elected officials and others who say that they want to do something, and if you want to move from the saying you want to do something to actually doing something, there's some key things that have to happen. 1 is equity has to be at the center of the conversation. A lot of times, we all know this, we will hear equity brought up at the end of a policy debate or after someone or a group or elected officials have come up with a strategy or a policy, that they will then sometimes reach out to some of you, some of us, and think, well, how do we go back and integrate health disparities or health equity? How do we get that into the mix now? And if there's going to be a genuine discussion, a genuine move for solutions, that conversation has to be there at the beginning. What are the policies that need to happen to sort of better balance the scales as we're talking about these issues? And that's particularly important as we're having conversations with our elected officials. So as they're moving forward to have these discussions, they really do have to factor in at the very beginning. And that's the key role for organizations like you to make sure when you're talking to these elected officials about changes, that they are including people like you, like your organization, at the table at the very beginning. Number 2, you have to support these community-based organizations like yourself, because again, there has to be a financial infrastructure to make sure that these groups that are out here doing the work can continue the work and provide some of the data, the resources, the input. But we've got to have the financial resources for these organizations to sort of move forward. And third, the third part of that is you've got to prioritize policies, expand coverage. Because without coverage, without giving patients access to this healthcare, to medicines, et cetera, a lot of this is a moot point. Let's move on to the next slide. And again, particularly when we're talking with our elected officials, there is kind of a wide net that has to be cast. It has to include a lot of different components. You've got to have input from a lot of different people. You've got 3 high-level buckets here: our healthcare industry decision makers, elected officials, policymakers, and our multicultural advocates and service providers. But again, and I know, and I'd said this previously, but I know in these conversations, a lot of times we're preaching to the choir because you are the folks out here doing the work in the communities every day. But let's just sort of highlight a few of these things. Like when we're talking about healthcare industry decision makers, compensate community leaders and organizations, provide expertise in policy development. What we have, and I really want to zero in on this, because what I've seen, and in my previous life, I shared this before, I was a legislative staffer. What I know, particularly when we are talking about healthcare or health disparities or bringing equity into the system, that is not a sexy subject for a lot of people. And a lot of people don't want to have those conversations. But what is critical just to be blunt, I think a lot of times when we're having those conversations, it's a higher bar, it's a higher threshold for us to sort of get engagement or get buy-in from policymakers and regulators. But part of the way, a critical way that we do that is that what we bring to the table is data. We bring to the table facts, and we bring to the table real life experience that can help further illustrate the impact of these issues. And so folks, particularly elected officials, understand this isn't like a feel-good, nice-to-do kind of thing. These are things that will fundamentally change the healthcare of the entire community. Because if you have parts of the community who are disproportionately being impacted by lack of access, lack of healthcare coverage, it is going to bleed into the larger community. So we've got to make sure that we are putting resources in place, and those resources can be used to pull together some of the data points and some of that information that regulators and others need to make some of these policy decisions. And a lot of that we know. Let's just go to the next slide. I just really wanted to highlight that. Let's go to the next slide. I think we can sort of skip over this. It's just sort of like a background. One of the things that we do want to focus in on today is rural health. And it's interesting whenever you having a conversation with elected officials and we begin to talk about rural versus urban, there are sort of automatic walls that come up because the urban legislators or the big city legislators are a lot of times are less interested in the concerns of the rural folks in the state. And we see that, I live in New York City, and we see that in Albany here in New York, when even in New York City, they're talking about the state budget and they're talking about resources for New York City versus the other parts of the state. Because are those two parts of the state very different? They absolutely are. But is one more deserving or less deserving of resources? Absolutely not. And so we've got to make sure that we do what we can to ensure that understanding of the balance and of the equity that is needed when you're talking about resources. And one of the things that sort of goes over a lot of folks' head when you're talking about building an infrastructure, making sure communities that have lesser access to healthcare have some built-in resources, what does that look like? One of the things is broadband, access to the internet. Because as we saw really during COVID, we saw this acceleration toward telehealth. And I think just like online shopping and these other things have accelerated since COVID, telehealth is the same way. And telehealth, interestingly enough, has the opportunity to be somewhat of a balancer in terms of access to healthcare. Because folks that traditionally have had problems with transportation and lack thereof access to sort of get to healthcare providers, telehealth can be a great equalizer. However, it can't be or won't be if communities don't have access to good broadband service. So that's one of the things that we need to talk about, continue the conversations, like when we're talking about a lot of the communities that a lot of our constituents are in, to making sure those communities have access to broadband. So we, again, some legislatures see that, but again, when we're having conversations with regulators, with elected officials, we've got to make sure something like that is built into the conversations and they understand the importance of broadband access, not just to access cable or other stuff, that folks in rural communities have access to good, solid, reliable, Wi-Fi. So in turn, they can sort of take advantage of things like telehealth. Let's go to the next slide, please. And again, one of the things that we're seeing, one of the hopeful signs that we're seeing in Congress, there's legislation, the Health Equity and Accountability Act, that addresses a lot of the things that we're important. And you see the three highlights. One, a more detailed reporting of demographic and health disparities data. It directs certain components of HHS to support health workforce diversity. And three, it increases access to culturally and linguistically appropriate healthcare. And I think this, as most of us that work in this space, we look at these three things and it's kind of a no-brainer. This makes absolute sense to us. But here's a couple things I want to highlight. What we're seeing in the country, there are a lot of things, I won't go too deep into this, but there are a lot of factors happening in the country now that are moving us away, further away from looking at creating systems that are fairer and provide better access to more people. I mean, there are strong efforts making to reduce the gains that have already been made. And so we have to remain vigilant. But one of the things that is very alarming is in that effort to sort of diminish gains and to diminish access is there is a deliberate effort in some spaces to reduce access to data, to reduce access to information that speaks to healthcare disparities. And I think that is so critical that we focus on that, because I think, like I said earlier, particularly in our spaces, if we are not able to come to the table with data, we're going to be in a diminished position. And so one of the things that's great about this proposed legislation, it sort of goes back and it looks at the importance of having that data. So again, as you look at some of this legislation out there, make sure you read the fine print, read between the lines, because there's a lot out there that can be critical as we think about things that can help improve or sort of better balance or sort of remove some of the inequities in the healthcare system. Let's go to the next slide. I don't think we need to go through the resources. So again, we sort of open this up for the group. What can your organization do to better collaborate? And that's a great question. And I know there's some questions of me. I'm going to sort of stop there and turn it back over to the moderator, and let's figure out what some of the next steps might be.
Okay, so feel free to go on video. Feel free to introduce yourself and the name of your organization, or feel free to type in the chat any responses you have to this question.
As we're waiting on some of the responses, maybe I'll kick it off a little bit. I think in a lot of the groups on this call are doing a lot of this work every day. And I know it's kind of a relentless effort, but I just need to say to you, your work matters, and it matters a lot. And again, as somebody going back to when I was a staffer, like, you've got to continue to raise these issues. You've got to continue to educate elected officials. One of the things that I shared with the group previously, I strongly suggest a lot of times you rethink how you're presenting some of the information. One of the cautionary tales I shared previously is oftentimes folks that do this work are so passionate about the work that they forget that sometimes the folks they're working with don't share that same passion. And so that's where we have to sort of double down on our data, what it means for the larger community, et cetera. And I see a question come in, so I'm going to stop sort of talking and let's see what the question is.
Okay, so we have from Tyler: work with community members to elevate the stories that help move the needle on important policy topics. Personal stories are very compelling for decision makers.
Would agree with that 1,000%.
And from Carrie: staying open and willing to learn.
completely agree with both comments as well. And, it's so important to be heard and to be seen. And I think one of the things that urban Indian organizations can do is make sure that you are at the table in communications with your urban leaders and with your state leaders so that they know you're there, they hear your voice, and they hear these stories. So I completely agree with both comments.
Coalitions are fantastic. Absolutely. Absolutely.
And Jessica says working with partner organizations like AHA, ACS CAN, those working on health equity coalitions are great. Emily says,
Add to that, one of the things
Okay.
that I've also seen as effective when you're talking about coalitions is potentially forming new coalitions. Because one of the things you might want to do, and this is a hypothetical, you might look for non-traditional partners in a coalition. For example, like if it's a healthcare issue, are there potential partners in the business community? Are there potential partners, if you're talking, let's say, because telehealth, like, and somebody in the comms. So I think sometimes in addition to the traditional coalitions, can you create perhaps additional coalitions that have greater diversity of a membership that might help you get greater reach? So something else just to consider.
From Emily, we have working with legislators and staffers to educate and elevate the importance of health equity legislation.
Absolutely.
And we have invite legislators to your events, example, National Public Health Week. I know you all are having so many community events every single week, every single day, but your state, local officials, all their email addresses are available online mostly. And from, your city council member to your mayor, to your state reps, to your state senators, they love to go to events like in the community and be heard and be able to see what you're doing. And that will help build those partnerships to be able to open the door to those conversations about legislation, about what you need. And Amanda says, promote visibility of Indigenous people in our urban communities. For example, be visible at public events and have conversations with guests about health equity issues. That's a great one too, showing up and holding your legislators accountable, showing them that you care, showing them that you're a voter and that these communities matter, all ties it back together. And I like Carrie with never give up.
That's another important one, just to remember that a lot of the folks, and particularly when you're talking to folks in a specific district, that they are indeed sort of constituents of that elected official. That's critically important.
Okay, do we want to keep going along? Okay, great. So now we will turn it over to Dr. Toedt, who many folks know from the Indian Health Service and who has continued his great efforts and supporting Indigenous communities and promoting health equity. And I will turn it over to Dr. Toedt.
Thank you so much, Meredith. I just want to make sure you can hear me okay.
You're coming through loud and clear.
Okay, fantastic. So I do think it's important that we take a moment to look back in order to move forward, because policy doesn't always move us in the right direction. So I want to share a few stories. Go to the next slide. So as Myron explained, at this Health Equity in Action conference, the discussion focused on practical solutions and the drivers of inequity in 4 areas. And so that included healthcare facilities and delivery, workforce pathways, research and data, and policy. And as we're focusing on policy today, I want to look at where policy can go wrong. Next slide, please. It's undeniable that policies of colonialism have severely and negatively impacted American Indians and Alaska Natives. And the history of our nation is stained by genocide, taking of native lands, and the denial of rights. Many are aware that policy, the Indian Removal Act, was signed into law by President Jackson in 1830, and that authorized the president to grant unsettled lands west of the Mississippi in exchange for Indian lands within existing state borders. While a few tribes went peacefully, many resisted the relocation policy. And despite a Supreme Court decision, Worcester versus Georgia, rendering a decision favorable to the tribe, declaring that Georgia had no jurisdiction over the Cherokee and no claim to their land, during the fall and winter of 1838 and 1839, the Cherokees were forcibly removed west by the United States government. And this happened to many other tribes in the Southeast, and approximately at least 4,000 Cherokees and many more from other tribes as well died in this forced march. And that became known as the Trail of Tears. So many people know about this, but what they don't know is that there are more recent policies of the United States that have also had lasting and devastating impact as well. So I want to focus on the policies of termination and relocation of the 1950s. Next slide. In 1953, the House passed Concurrent Resolution 108, which was then also passed by the Senate. And with that resolution, the House and Senate together announced their support for a new Indian policy, termination. Under this policy, approved unanimously by the Senate and House, Indian status as government wards would be ended as soon as possible, and Native Americans would assume all the responsibilities of full citizenship. I'm quoting the legislation. This was despite the fact that American Indians had been granted undeniably as citizenship since Congress passed the Indian Citizenship Act in 1924. Under Concurrent Resolution 108 and the policies flowing from that legislation, 109 tribes and bands were terminated, directly impacting over 1.3 million acres of land and 11,466 people. Next slide, please. There were 4 relocation sites set up in California: Los Angeles, San Francisco, San Jose, and Oakland, as well as the cities of Chicago, Detroit, Cleveland, Dallas, and Denver. Los Angeles and San Francisco Bay Area were designated as vocational training centers. Thousands of Indians were moved off reservations to the cities in an effort to force assimilation. Many of today's elders in urban areas were relocated during this period. BIA relocation programs looked at least hopeful to Indians for a better future, as you can see on the advertisements on the screen, and most intended to eventually return to reservations despite the relocation. Adjustment to urban dominant society living was very difficult for most Indians, and many returned to the reservations without completing the relocation program, but many stayed. Urban Indians suffered the same racial discrimination and inner city dysfunctions as other minorities. Some of those who stayed established Indian cultural communities within the urban environment and helped create the pan-Indian movement of today, and still persist and thrive and survive. Next slide, please. So what can we learn from the past? I mean, this is very recent legislation. I think the bottom line, number one, is that policies designed to affect or manage a population that are not supported, developed, and embraced by that population, even if well-meaning, are doomed to fail. The bottom line, number two, is that policies that ignore or otherwise intentionally or unintentionally leave out a population, like we see with data collection, are highly likely to cause or exacerbate inequity and disparities. And a little bit more about bottom line number three, nothing about me without me. It's not just IHS policy that I'm talking about, or BIA policy, or Indian policy. Whether it's policy, broad policy on housing, urban development, jobs programs, educational programs, transportation, infrastructure investments, broadband expansion, food and nutritional programs, or the many programs that directly affect health services and public health programs like Medicare, Medicaid, HRSA grants, or other programs through HHS, the rules around FQHCs and community health centers, CCBHCs, which are SAMHSA policies, CDC, the Centers for Disease Control, or any federal, state, county, or municipal program. The mantra has to be nothing about me without me. Next slide.
Thank you, Dr. Toedt. All right, I'll take it from here then. Well, thank you both for these wonderful presentations and great discussion points today. We certainly have, we know that we have a lot of work ahead of us, and that our partners do make it possible for us to continue to develop better policies going forward. We wanted to take an opportunity to highlight a little bit of the National Council of Urban Indian Health's work as it relates to the Pfizer Health Equity and Action Guide, which I've tried to include a link in the chat, but if that did not work, someone please tell me. Okay, maybe it's working now. Okay, so for those that don't know, the National Council of Urban Indian Health is the national nonprofit devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives in urban areas. We represent 41 urban Indian organizations receiving contracts from the Indian Health Service and the Indian Healthcare Improvement Act, and we strive to improve the health of the over 70% of American Indian and Alaska Native populations that live in urban areas. So our partners here who are in the Indian healthcare space are very familiar and address the social determinants of health and disparities you see here every day. But for our partners, we do believe it's important to ground why this work is so necessary and share some of the disproportionately high rates that are experienced in infant and maternal mortality, cancer, alcohol and substance abuse, suicide and depression, and diabetes. And at this point, the life expectancy is now 7 years less than the national average for Native American people. And this was the overall US life expectancy almost 80 years ago for the general population. That is where Native people are today. And this is a clear health equity issue impacting Indian country, which NCUIH is working to address. So recently in July, Pfizer released the Health Equity and Action Guide, which includes policy priorities identified to improve health equity. Several of NCUIH's policy priorities for improving urban Indian health align with the policy priorities identified by Pfizer in their Health Equity and Action Guide. I'm going to highlight two specific priorities, and specifically full funding and Medicaid, and discuss some overlapping legislative priorities as well. And we can move forward. Thank you. And to the next one. Thank you. The Health Equity and Action Guide identified that funding opportunities must be made available to tribal and indigenous communities who often suffer from some of the worst health outcomes and have the fewest resources to implement programs. The Indian health system is chronically underfunded, and it shows in the alarming health disparities faced by Native people. Tribes have requested that the government fully fund the Indian Health Service, but the government continues to fall short of the $51 billion needed. Despite the unceasing work and dedication of the Indian Health Service, tribal and urban Indian organization staff, they simply do not receive the required financial support to address the systemic health inequities in Indian country. Through letters to congressional appropriators, testimony before Congress on the budget, and comments to the Office of Management and Budget, NCUIH and UIOs have worked to increase funding for the Indian Health Service and urban Indian health over the years. In fact, in 2022, we successfully advocated for the largest increase in funding for urban Indian health, and we were able to get advanced appropriations for the Indian Health Service in the final bill, meaning that the Indian Health Service will stay funded in the event of a government shutdown. Full and stable funding for the Indian Health Service, including urban Indian health, at the amount requested by tribes is necessary to achieve health equity for all Native people, no matter where they live. Another identified policy priority in the Health Equity and Action Guide is Medicaid access and reform. As Myron touched on, without more coverage, people will fall between the cracks, and it's important that these opportunities be made available. Medicaid provides critically important coverage to Native people, specifically urban Native people. Looking at the importance of Medicaid for urban Indian organizations, in 2021, 51% of the total patient population and 46% of the American Indian and Alaska Native population were Medicaid beneficiaries. Medicaid serves as a critical source of supplemental funding for UIOs who have been chronically underfunded by the federal appropriations process. And in fact, Medicaid remains the largest secondary source of fundings for urban Indian organization clinics besides the Indian Health Service. In the Health Equity and Action Guide, Pfizer specifically states that to create more equitable access to care for Medicaid enrollees who are disproportionately people of color, Medicaid rates must be sufficient to ensure the availability of quality care. One of NCUIH's top policy priorities is setting the federal medical assistance percentage, or FMAP, for Medicaid services provided at urban Indian organizations to 100%. We call it 100% FMAP. This refers to the percentage of Medicaid costs covered by the federal government and reimbursed to states. Congress first authorized 100% FMAP for the Indian health system because they knew that the funding for IHS alone was not sufficient. Unfortunately, urban Indian organizations were not included in the initial authorization, which means that states have to cover part of the bill for services provided to IHS Medicaid beneficiaries, and they have less financial flexibility to support our urban Indian health clinics. In 2021, urban Indian organizations worked with Congress to authorize 2 years of 100% FMAP, but this expired in March, and states are back on the hook for a portion of the cost, and we're back to where we started. While several states benefited from this period, 2 states were able specifically to use this provision to directly benefit urban Indian healthcare, as we and Congress had intended. One state was able to reinvest its savings, and it allowed them to provide $11 million to its 2 urban Indian organizations. And another state was able to temporarily increase its urban Indian organization reimbursement rate by 61%. It has provided with its urban Indian organizations with over $500,000 in additional funding, which they can now use to construct, a new clinic, and expand with a new behavioral health unit. These successes demonstrate that making 100% FMAP permanent is essential, not just for providing the healthcare to urban Indian organization patients, but also for providing urban Indian organizations with much needed financial flexibility to address the needs of their patients. On November 30th, the Urban Indian Health Parity Act was introduced by Representatives Ruiz and Bacon. This bill would permanently extend 100% FMAP to urban Indian organizations by amending the Social Security Act to set the federal medical assistance percentage at 100% for services provided to Medicaid beneficiaries at urban Indian organizations. Another health equity issue relating to Medicaid access that we've been working on recently is Medicaid unwinding. Medicaid unwinding refers to the resumption of the annual Medicaid eligibility reviews, which began on April 1st of this year. After the end of the continuous coverage requirement required by the Families First Coronavirus Act. NCUIH and other civil organizations, as part of the Civil Rights Health Equity Working Group on the Unwinding of Medicaid, released a report on the first 6 months of Medicaid unwinding. The report estimates that around 400,000 Native Americans were terminated from Medicaid during the first 6 months of unwinding. I also wanted to highlight 2 bills that NCUIH has endorsed that were included in the Health Equity in Action Guide. As mentioned earlier, NCUIH endorsed the Health Equity and Accountability Act and worked with Congress on provisions included within this legislation. As a comprehensive public health reform bill aimed to address and reduce health disparities in the United States, it includes numerous provisions that would directly impact and benefit Native people, including 100% FMAP. We are working with our congressional partners on the reintroduction and passing of many of the provisions in this bill during this Congress. We also endorsed the Black Maternal Health Momnibus Act. This bill includes urban Indian organizations as eligible entities to receive grant funding to support maternal health services and data collection. Now I'm going to open up the floor for our panelists to answer some questions relating to health equity. Structural racism in health. Oh, we can take the slides down now. Thank you. Structural racism in healthcare results in inequities across outcomes, spanning income brackets, education levels, and geography. The insidious nature of institutionalized racism and its long history in the United States mean any successful effort to address racism in healthcare require comprehensive, multifaceted, and innovative approaches. Policy, whether at the state, federal, or local level, and across the domains of health, environment, and the economy is necessary to ensure these forms are implemented widely. When reflecting on your personal experience and professional career, which healthcare policies do you think could be implemented to establish a more equitable, comprehensive, and adaptable healthcare reform?
Meredith, if it's okay, I'd like to take a first shot at that. Yeah, thank you so much for the question. And first, let me thank you for an excellent presentation. NCUIH has been such a powerful advocate for American Indian, Alaska Native health, and your continued work is just amazing. So thank you for that. So yeah, with regard to structural racism, you know, one policy that comes to mind immediately to me is the policies around graduate medical education. And there's not just one policy that affects it. It's actually the policies of CMS, to some extent of HRSA, and to some extent of the VA. CMS is the largest funder of graduate medical education, followed by the VA, and then some rural family medicine and internal medicine and other primary care programs are funded through HRSA, mostly again in rural locations. But the funding mechanisms through these three sources are not readily available to tribes, to IHS, and to urban Indian organizations. There are some shining examples of success where tribes or urban Indian organizations have paved the way and figured out workarounds around some of these policies to get some funding. But clearly there are challenges in these programs, whether it has to do with the cost reporting structure, whether it has to do with eligibility to apply for certain funding streams, restrictions on CMS funding being only eligible to hospitals and HRSA funding to non-hospitals. These types of challenges present specific barriers to tribal and urban Indian programs as well as IHS programs. So that one, graduate medical education, to me comes to mind. I would like to see the policies that the current administration has endorsed on requirement for tribal consultation. I would like to see tribal consultation and urban confer of all of these departments and agencies. So HHS, at the HHS level, to bring together CMS, IHS, and HRSA, and allow tribes and urban Indian organizations to have that direct voice on the policies and regulations that govern those processes. And then further beyond HHS to include the Department of Veterans Affairs. The Mission Act of 2018 endorsed additional funding for IHS and tribal sites. But again, how that rulemaking is implemented, I would like to see American Indian, Alaska Native voices at the table in helping to remove some of those structural barriers that make it harder to participate.
Wonderful, thank you. And in developing new healthcare policies and systems, equity must be prioritized and incorporated from the start. One example of an existing framework for health equity created by the Century Foundation identifies 5 pillars: affordability, sustainability, accountability, comprehensiveness, and inclusivity. Health policy will only be equitable if it centers the needs and vision of communities that have been systematically oppressed. And to do this, those communities must be involved from beginning in policy formation. What are some ways to effectively involve and empower Native communities in the early stages of policy formation?
So certainly when those policies are coming from the federal government, that requirement for consultation and confer has to be exercised. When the policies are coming from the legislative side, again, having the voices of NCUIH, of the National Indian Health Board, of the National Congress for American Indians, other organizations that advocate for American Indian and Alaska Native health, they have to be at the table early and consulted early in terms of how to make sure that that people are not left behind. I think also we have to look beyond just healthcare policy, because we know that 20% of what affects your actual health is healthcare delivery, and the 80% of what affects health are the social determinants of health and other factors outside of an exam room, right? So we need to think about policies on housing and on education and on nutrition availability, working to eliminate food deserts. All of these issues need to include American Indians and Alaska Natives from the start.
Thank you. Yes, the tribal consultation and urban confer policies are really essential in order to ensure that the needs of the community are really understood and driven by the needs of the community. Regarding applying a health equity perspective throughout the implementation, planning, and evaluation phases using both new and existing and new authorities. We have to apply that throughout those processes. And to address racial disparities in healthcare, it is crucial to allocate funding to community-led groups. Urban Indian organizations are especially effective in underserved communities, but they are often underfunded and impacted by the existing funding stream process. So these critical organizations experience difficulties accessing grants due to a lack of resources and limited staff capacity. What measures can be taken to support urban Indian organizations and our partners when they apply for grants?
A great question. So the first thing is to be included, because so many times grants or funding opportunities are not even available to urban Indian organizations or to tribes or the IHS, right? So the first thing is number one, to be included. I think the other thing is that when grants have a high bar for data collection and reporting requirements, it can be challenging for a small organization to meet those requirements. And certainly, we want data. Don't get me wrong. And you know, it's just that the burden of data collection, the systems required to implement data collection, those require funding and time as well. So when the grants are written, if there is a data reporting or collection requirement, the funding should address that as well, and should make sure that urban Indian organizations and tribes are appropriately resourced to meet the needs of the requirements.
Wonderful. I couldn't agree more. One thing we do when we go through legislation is really, first of all, we try to understand the intent. And if the intent is to reduce health disparities, we go through and find out, are the Indian Health Service, our tribal organizations, our urban Indian organizations listed or mentioned? And how can we ensure that they're, especially in fulfillment of the trust responsibility, have access to these funds and with minimal reporting requirements or burdens to get the funding in the first place? It is important to ensure that the healthcare coverage and treatment are both affordable, and in order to achieve health equity in the United States, Medicaid and the CHIP program are responsible providing health insurance to individuals with low incomes. And as of December 2022, more than 90 million people were enrolled in these programs, which play a vital role in the social safety net. Medicaid is especially important for providing coverage to people of color, but further efforts are necessary to improve the system. Inadequate health insurance coverage is a significant barrier to healthcare access and often causes patients to delay and avoid medical care altogether, exacerbating the significant healthcare disparities faced by underserved communities. What changes can be made to the Medicaid program to support these communities and urban Native communities?
Yeah, great question again. You know, one of the challenges that many programs have faced, and it's because of the different decisions made in different states, is whether or not Medicaid has expanded, and then when it does expand, to what extent that expansion gets out into various care settings. So one example I have in mind is after a long spell, North Carolina recently expanded Medicaid, and that's huge and going to make a tremendous difference for residents in North Carolina. But one of the things that the state did, which is even beyond what other states have done in some cases, is expanding that Medicaid coverage to women beyond just the shorter postnatal period, to extend out a full year. Another thing that they've done is to expand Medicaid coverage to those who are incarcerated. And that's a big one because in many states, Medicaid does not cover those who are justice involved, particularly those who are incarcerated. So I think that looking at the special issues around pregnant people, the special issues around justice involved populations and other particularly vulnerable populations, and how Medicaid can specifically ensure that there's access to care and funding for those populations will be very important.
Thank you. Couldn't agree more. Well, that brings us to the end of our time here today. I would like to thank Dr. Toedt and Myron Terry and Pfizer for all of their support and for their continued partnership as we work together to tackle and improve health outcomes for Native communities and all underserved communities.
Thank you.
Thank you. We will send
Thank you
the
so much.
slides to participants as well as a recording of this event as well. Thank you. Happy holidays. Happy New Year.
Thank you.